The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, and I'm here talking to Dr. Jacopo Olivoto, and he's a cardiologist at the HCM Center at the University of Florence. He's published a really interesting paper in JACC that deals with currently a challenging issue, that is the role of genetics in hypertrophic cardiomyopathy. So tell us about this study that you published. What were your findings?
Well, can I briefly talk about the history? We've looked at HCM patients for like 30 years, and we've only had genetic testing in the last 10 years. We were quite stunned to find very frequent occurrence, or relatively frequent occurrence, of multiple gene defect. And we found families in which there were as many as 3 different HCM-causing mutations at the same time. So we said we should look more closely into these very unique families, and that's what we did here.
Sure. So as I recall in the manuscript, what you did was you screened a very large number of patients, over 400 patients, looking for really contractile myofilament genetic abnormalities.
That's right. About 50% proved to be positive for at least one mutation, 5% had 2 different mutations, and less than 1%, which is the content of the paper here, had 3 different mutations. These index patients with 3 different gene mutations had very, very severe phenotype, very severe clinical outcome in terms of arrhythmias, sudden death or cardiac arrest, and also evolution towards the end-stage phase.
And as I recall, they presented earlier in life with these very severe manifestations.
They did. It is already known from the literature that you have multiple, if you have 2 defects, your disease will be earlier and more severe. And here, this is even more striking. By the age of 25, each one of these 4 patients had massive hypertrophy, which eventually tapered into thinning of the ventricles and evolution towards the hypokinetic dilated phase.
Right. Now, these 400-plus patients, they all had the phenotype of HCM.
They all had unequivocal diagnosis of HCM, and they were unrelated patients, yes.
So now, as we extrapolate these findings, it's clear that if you have 3 mutations, that you have very severe disease, but the number of patients that have that is a very small percentage. Does that warrant genetic testing?
Oh, absolutely so. I mean, this is obviously a proof of concept paper. So obviously we were looking at the very, very tip of the iceberg. But what this and other papers tell you is that genetic testing is now useful, because it's not only something that may confirm a diagnosis in relatives of patients, it is something that may help management. For example, if you have a mutation, you're more likely to end up in heart failure than if you are genotype negative, although we don't know what genotype negative patients have, and more research is warranted here. If you have more than 1 defect, and you have to have 2 or 3 defects, that's a smaller subset, but it's still significant, and these are patients who need a lot of attention, very early thoughts about switching treatment from, for example, classic pharmacological treatment of HCM to heart failure treatment, including ACE inhibitors, including SARTANs, as soon as you see that the ventricular function is tapering down, and you must not wait until they have overt heart failure in dysfunction, as you would in post-MI patients, for example.
So I would be interested, have you yet encountered any patients with multiple genetic defects that didn't have the phenotype of hypertrophic cardiomyopathy?
Not to my knowledge, not that I know in the literature. It is quite unlikely in my opinion. However, that is always an option, and if that occurs, one is always concerned that one of the mutations you found, if it is a novel mutation, not previously described, it may always turn out to be one of the so-called variants of unknown significance. So mutations which may just be polymorphism and not be effectively causing the disease. So that's what I would try to exclude. And we need a lot of research to find out more about these novel mutations, which are many and which have not been previously found in other patients, to understand whether they are actually causing the disease or just modifying or just doing nothing.
Sure. So having managed to identify this group of patients as you have with multiple mutations that are at very high risk, do you think now that we're in a position that genetic testing should be done in virtually all patients with phenotypic hypertrophic cardiomyopathy?
Absolutely so. I think genetic testing is now coming in the clinical arena. It is becoming very important for us to know the genetic background of the patients, because that is helpful in, to some extent, guiding management. Also, it is important to guide further research, because now we are on the verge of, for the first time in HCM history, thinking about multi-center trials, randomized trials. We have new pharmacological agents we can use, and we can only do this properly if we match patients as much as we can based on their genetic background.
Well, thanks very much. This is a very interesting paper, and one I'm sure our audience will want to be sure to read. For the Genuine Article, I'm Tony DeMaria.
The Genuine Article. Discussion and commentary based on articles from JACC.